no idea about sex toys, for example. So as for myself, first of all, I felt I was not missing anything. That was the first thing that came to my mind. And then regarding me as a woman, led me into thinking that, quite frankly, my disability may have never been a real problem for men. If you want to engage in a sexual intercourse with a man, you'll find him, The point is whether you can or you can't, whether he likes you or not, the most difficult part is the actually emotional side. That is rather more difficult to cope with, and it is even more difficult for men to get a handle into this part of the whole thing. I might want to be a trainer here one day or another. Anyway, first of all, self-awareness was really the starting part of my being in a love story. I really felt like I was not good at that at all. I felt like nobody might have favored me, might have thought that I was better than a regularly walking girl, in spite of her maybe being, a fool. But in sexual terms, in strictly sexual terms, I was okay. I always compare myself to my own sister. Actually, she doesn't like any sports. She doesn't like, going trekking or running. So the point is not that she can't do it. She could, but she is not interested at all. So I can't go on a trekking tour, but I couldn't actually, even if I wanted to. That's the only difference. So she doesn't want to, she's not interested. So why should you put limitations to experiencing? Another example, Guido, my partner, and I would like to go to Japan. Okay, well, with my wheelchair, I may have troubles in going as far as Japan, but we'll make it. Maybe he will see all of the Japanese temples. I'll see half of them. What's wrong with that? After all, I believe that you cannot only think of what you cannot do. You might want to consider things from the perspective of what you can do. Thank you. Thank you both. Well, you can get in touch with Max directly. But I particularly liked what you said about the personal approach, so the need to try and forget about one's own limitations. And I think this also goes with the social-cultural framework where one is. So what is your perspective here? What can you see in the current society? Let me make one point clear. We are talking about what I cannot do. Okay, let's try and do without this. Okay, let's put this aside. People are able-bodied or not able-bodied. Okay, there may be ordinary people, if you wish. Let's talk them like this. If I you know, I mean, if I go into a room where everybody's on a wheelchair and I'm not on a wheelchair, I'm the strange one, I'm the funny one. So let us change, the words we use. So one of our most common mistakes is precisely to consider things from this perspective. What can I do? What cannot I do? Well, you've talked about sexual intercourse. Well, let me tell you that I sometimes go to schools and talk, high schools or universities. And a couple of days ago, I went to a high school and I talked to the students about sexual intercourse and asked them, what are we talking about? What is a sexual intercourse to you? And a girl, uh, one of the women in the room told me, well, for me, sexual intercourse is penetration. If there is penetration, then I can talk about it being a sexual intercourse. So if it touches your breast, that has nothing to do with making sex, right? No, not at all. Making sex goes with penetration. That is what a sexual intercourse is about. So I told her, look, if I come to see you and touch your breasts, I'm not making sex to you. Well, it depends. If you're my boyfriend, okay. But if you're not my boyfriend, it could be an abuse. An abuse of what? Sexual abuse. Well, then I'm making sex, all right. So, I mean, people are a bit confused here, especially, among, young people. There's nothing that you must do. There's not a sort of a menu that you must go through from the appetizer to the dessert. So penetration and sex, well, that is one part of it. So some people may find it difficult to engage in some activities, but precisely because of that, they feel like they cannot go into that. Whereas I believe that sexual intercourses and sexuality are about a lot of things. There's not a list of rules that you must comply with. That is not the case at all. And this is what often people think, though, in our society. So sometimes I speak to an audience, even for less than 30 minutes, and I often feel like I'm doing quite well, compared to the people who are listening to me when it's about sex, which is quite surprising, because I mean, there was no internet when I was a young man. I mean, I could not see any particularly meaningful pictures in terms of sex, whereas now you may come across many, more such pictures. What is a sex toy? Well, one answer was, I will never use a sex toy because I'm not a gay person. I mean, can you realize how difficult it is to approach sex as even very young people? Well, let me say that there's often a performance-related problem. Sexual performances seem to take the lead here. Also because sex education is basically what they get through porn videos, which, I mean, have nothing real. That is not the reality of a sexual relationship. You cannot actually measure. You can't truly appreciate the beauty of a sexual relationship based on the number of positions you take in bed. Who cares? Who cares? Well, try and be careful with the use of words, to appreciate or measure this might be misunderstood. But I really feel like there's a lack of education here. People are not properly educated to affectivity and sexuality. If young people keep getting their education in this way, well, their view of a real intercourse will be very far from reality, and it will certainly not be satisfying at all. Well, even Rocco Siffredi says so. I mean, porn film star. And of course, we cannot say anything different from what he says. Now, our last slide is about our question regarding the possible solutions, if you wish, to a way out of all of this. So, what can we do? So, first of all, more autonomy, more independence, privacy. I mean, if my parents are in the room next to mine, how can I actually find the right response to my needs? And then, of course, raising awareness. This is also very important, which is what we are trying to do today, for example. And then taboos. We are also aware of that. So my question goes to you too. What do you think we should do in order to make what we've said happen? So, the three ones in the list are quite self-explanatory. Actually, I believe one should be, self-standing, so to speak, also from a different perspective. And I'll give you an example of that. When you can be on your own, you can go everywhere. You can go to one place or another one where you can meet a partner. You can meet a partner in a pub, but also the bakery. Of course, if I can actually have access to such places, which include means of transportation, for example. But there's also another problem, namely most disabled people need to be accompanied somewhere. So, parents, no way, of course. I mean, I couldn't possibly think of my parents getting me to meeting people with whom to engage in a sexual relationship. No, I couldn't possibly think of that. So we might need, I don't know, an accompanying person, an assistant. But I mean, I think we might want to ask our staff to fill in a questionnaire which is supposed to include a certain number of questions. For example, what do you think of sexuality and disability? What about going to a pub or a club where you see, young people waiting for sex? Or what about taking me out for a, nightstand while my parents are sleeping? Maybe the answer is no, I can't do that, because if your mother knows that, then I'll lose my job. So that is precisely the end of the real meaning of an accompanying person who's supposed to be there for you to do whatever you want to do, even the least meaningful things. So I believe raising awareness is of paramount importance. Of course, we know that the human body is viewed from quite a stereotype like approach. But this kind of questionnaire might, serve the purpose. I remember, and Marica will probably remember too, that there was a boy once who, after listening to me, had changed his mind. Now, the floor to you, Lulu. Well, I believe the three items in the list say it all. This is precisely what we are supposed to do. As for being on one's own, as for being independent and autonomous, we might want to have some accompanying persons who are supposed to do just that, accompany us. Sometimes we know, though, through other disabled women friends that these people often ask silly questions like, what about this makeup? Are you using it because you're out to meeting someone? Well, I think that this goes with the so-called ableism. You might want to use a sexy bra. The accompanying person is supposed to help you do that, but she is there to judge you, so that's not good. I perfectly agree. We should include these kind of questions in our questionnaire. You're not supposed to judge me, to judge my dress code. And then living on one's own. Well, I have always had some accompanying persons, mainly friends, mainly, women friends. They took me to a meeting that particular boy that I was interested in. Well, those have been my weapons, and I believe we all have different weapons. Max, I believe this commission might serve the purpose too, right? Ableism should be reconsidered. Ableism in accompanying a person, of course, in assistance. Well, that's true. The idea is to allow disabled people to be as autonomous as possible. Of course, there may be some limits to that. Let us just consider intellectual disabilities, which are even more complex to be coped with, but the aim is the same. Thank you very much. Any questions? Any remarks?
Sono timidi. Faccio delle domande,
Sono timidi, io non li farei fare a Max.
Per favore non fate fare domande a Max.
Okay, Max has many questions, but maybe you'll want to ask your questions.
C'è una domanda.
Okay.
Una domanda.
We have one question.
Sì, sta arrivando.
Vittorio, vuoi avvicinarti così? Ce la stiamo facendo? No. No, aspetta.
Problemi di microfono.
Ma infatti. Allora, ciao Max, ciao Lulu.
Hi, Max, and hi, Lulu. You talked about sex toys. To what extent can they be used in terms of a disabled person's independence?
Vai.
Secondo me, innanzitutto, una bel excursus sui sex toys io lo consiglio a tutti.
Well, actually, sex toys should be better people should be better aware of sex toys independently of disabilities. But actually, some sex toys are very good for some disabilities in particular. I have worked, for example, at a project on sex toys for people with very reduced mobility. So I took part in the drawing up of many relevant questionnaires. But actually, when we talk about people being on their own, people making it on their own, we really want to know what these people actually want, because sex toys are so different. They may excite different parts of the body. I'm sure Max knows better here, but it might be good, for us all to have a special training course on sex toys. Okay, you might want to talk it with many different names, but anyway, I talked to you about the 17-year-old, high school students who should know much more. But he was the one who said, "I'm not a gay person, therefore I will never use sex toys." Well, the reason behind that is very simple, and here it comes. He thinks that sex toys are only the one with a phallic shape. Well, first of all, when I said phallic, everybody looked at me and did not even know what I was talking about. I'm talking here about high school students. You might want to remember that. So I tried with, Willy, Billy, or something like that. Maybe they could understand that better. Anyway, he said, "I'm not a gay person, therefore I just have one orifice, and I can, that is an orifice that is used through the sex toys only by gay people." So this is just a lot of stereotypes altogether. So first and foremost, we need education. But then, as Lulu rightly said, many sex toys may be very good for some special disabilities. Of course, if you're on your own, that's one thing. If you're in a couple, maybe you can use them with your partner. So if I have some limits, well, I may use some special tools to help me out. But actually, it works, and it's a world that we might want to investigate more.
Ci sono altre
Thank you.
domande?
Thank you. Any other questions or remarks?
Mamma mia, che timidezza.
You seem to be very shy. Well, if I had been there, I would have asked you personally, says Max. Maybe you have another question, Max?
Non l'ho fatto però. No, allora, no, più che domande,
Maybe you have one in your mind? Okay, I will not ask that one question, but
ruotata.
Sì,
Se gli va,
maybe some of you who are in a wheelchair,
no.
and some are laughing right now. Is anybody raising his or her hand now? Okay, not voluntarily. Anyway, some of the wheelchair people might want to either ask a question or make a remark. After all, we're among friends. Anybody wishing to tell us about their experience, even their non-experience?
Pare di no,
Dai,
però
chiamo io a caso. Ne ho visto uno lì con lo...
There's one of you wearing glasses.
sì, mi sento in questa situazione di preservare un pochino i miei ragazzi.
I feel like I should safeguard my boys, Actually, we did ask them to ask questions also anonymously, okay? So I may have some of these questions.
Antonio, tu ce l'hai a disposizione? Mi faccio aiutare dal pubblico.
Allora, erano arrivate alcune domande.
So some of the questions may have already been answered. Anyway, how can a sexual assistant help when the assisted person is on his own and without a real partner? This could be a double-edged sword, couldn't it?
Allora, io rispondo ovviamente in maniera generale,
Well,
senza che conoscendo il
I'll
ragazzo.
give a general answer because I don't know, of course, the person who asked the question. So, let me stress what I have already said. The target is autonomy, independence. So, you might want to have some assistance, properly trained assistance, if then you have more opportunities to engage in a relationship. Now, if you're a disabled person, that does not mean that you're not supposed to be in a sexual relationship. There may be other problems, shyness, or simply the feeling like you can never be in a relationship. So it's a mindset that may take you somewhere. You then feel differently for the people that you're faced up to. You might never have a sexual relationship if you feel like you'll never have one, or maybe you can have people wishing to play to do charity, with you, or maybe people who are just coming out of dramatic, tragic love stories. So you might not want to have any of
Quindi
that.
essenzialmente come ci sentiamo può essere importante. Un percorso, un assistente
So,
può sbloccare questa
having an
cosa.
accompanying person
Sicuro che
that
questo
is
supporto,
properly
questa
trained
conoscenza
may
ti
help you
può
feel
dare
more
questa cosa.
confident
Non è
about your
matematica, ti
own
giuro, non
body.
solo, non è matematica,
That
perché la sessualità
does
deve essere
not
moltiplicata,
mean that
non solo
you'll get
legata
out of it
all'estetica,
for
questo è un
sure.
dato.
It's
Però anche
nothing
l'interno,
mathematical
certamente
there,
potrei
nothing to be
stare in
taken
casa,
for
potrei
granted. But after all,
appunto fare
it's a
niente,
way
pensare
to
che
try and get out of
fondamentalmente
one's own bedroom.
Io vorrei rispondere
I'd
al
like
proposito del
to
discorso dell'assistente sessuale.
answer to
Sono
this
d'accordissimo
question.
con Max sul
I
discorso
agree
che
with
bisogna
Max
lavorare un po',
when he
come
says
dicevo
that
prima, su se stessi,
we
cioè
need
su quali sono le
to
proprie skill,
work about
perché
oneself and
è ovvio
about
che se io non
one's
conosco quali sono
own
i miei
skills.
punti di forza, le mie
Because if I
capacità,
don't know about my
anche la
strengths,
timidenza può essere una skill. Perché molte
which
persone piacciono le
may
persone timide,
include
piacciono le
shyness.
persone
People like
e
shy
potrebbe
people.
benissimo
I do,
anche
for
in
example. I'm
realtà io
not a shy
adoro i ragazzi
person,
timidi,
so
un
I
sacco di
love
ragazzi che adorano i
shy
ragazzi timidi, sono
young
ragazzi
men,
timidi.
and there are
Quindi,
many more women
quindi
or
certo,
men
dipende
actually
molto
who
su quali sono i reali
feel the
caratteri, non è
same.
se tu sei
So,
una
first of
persona
all, you should
grigia
know more
come
about yourself.
bagnato
If you're a
e
shy
quindi
person,
è capito,
there's
sempre che
nothing
preferisco
wrong in
perché
that.
è ovvio
You must always
che
try and be
se tu
yourself.
fingi di essere qualcun
Because
altro,
if
no?
you
Cioè
pretend to be
è
somebody
facile
else,
fingere
well then,
anche con te stesso. È logico che uno potresti fare un
such a
lavoro
self-pretense
sul discorso
might
della
not
sicurezza, perché
get you
se
anywhere,
sei timido o non timido non cambia assolutamente
and
niente.
it might not
L'autostima è una cosa che va coltivata e tutti
take
i
you
giorni va
to
coltivata perché
getting
sono tutti solo delle
more
persone
self-confident. And
oggettivamente
by the way, this goes
sbagliate,
for
anche
disabled
da
and even
autostima.
not
Ci va
disabled
benissimo
people.
anche
Of course, disabled
a
people may find it particularly
sì,
hard to
diranno che un giorno diventi
retrieve
duro e quindi non sei
self-esteem.
fantastico. Parto dal presupposto che ci sono anche
One
quelle
day may
persone
be okay, but
come me,
another day
che sempre all'altezza, non ti
may be
senti
exactly the
pronta, non
opposite.
ti
You don't
senti in grado di affrontare
feel
qualche cosa. Quindi io credo
that you
che
can live
bisogna
up to some,
coltivare innanzitutto l'autostima e
expectations.
poi
So
avere
first of all,
conoscenza delle
self-esteem,
capacità
and
da
then
poter mettere
a better
poter
self-awareness
sfruttarle,
of
poter
your
mettere
own skills
sul
that
piatto
you
a
might
seconda
want
di una
to
conoscenza, di una
use
relazione
when you start engaging in a relationship. What am I actually giving to this person who is apparently who apparently wishes to know me better? And of course, I'm not thinking of sexual performances in their own right, but I mean, am I a supportive person, or am I a person who can, help people retrieve their energy?
Sottolineare su di una cosa che ha detto
Let me stress
Lulu, che fa parte
one of the
di
things
una
that
via
Lulu has
comunicazione estraordinariamente
said.
spesso alle pedine di ogni genere ha
I get
fatto.
much mail about this,
L'argomentazione è
and
spesso quella del tipo
what I often
a
read
me non mi
about
vuole
is
nessuno.
nobody
E
wants
io
me.
rispondo proprio come ha detto
And
Lulu.
this is precisely my
Perché
answer,
non vorresti nessuno
Lulu's
se non
answer is
magari
mine answer.
piuttosto
Well,
perché
try
qualcuno
to
qualcuna
change
potrebbe
your
avere interesse.
perspective.
Capite?
Why should I
Non
want you,
insiste
or
in
why should
messaggi
you
proprio di
want
testo,
that
40 anni
person?
disabile
I
molto
mean, if you
sensibile,
write, I'm
punto.
40 years old,
Ci
I'm a
sarà un
disabled
senso.
person, and I'm a very sensitive person, and that's it. Well, I'm not sure much will come out of that.
Questo tema del partire dalla conoscenza di sé
So,
diciamo,
self-awareness,
quindi per me è molto
of
importante,
course,
ma in realtà
goes
poi
very
alla
well with me
fine
since I'm a
le persone che
psychologist,
pensiamo delle nostre
and
caratteristiche non
this
possono avere
goes for
delle
anybody, not
però
only
conoscere le
disabled
nostre stesse punti di vista e
people,
le ragioni di confronto per
for
le
whom,
quali siano
however, this might turn
e noi nel
particularly
centro ascolto cerchiamo proprio
difficult. So in our counseling center, we precisely try to make this possible to more and more people, both in private relationships and in institutional events such as this one. There will be a special time within this conference precisely devoted to this. There will be a facilitator, Giuseppe Giardina, from the Sicilian Counseling Center, a psychologist, and Bontisci from Lombardy, who is an educator in charge of a relevant project. So you can go to the orange room. -1 is the floor where you'll see this room. So thank you very much, Max and Lulu. Thank you for what you do and for what you do normally, beside, of course, the event of the conference. Now, some announcements.
vi ricordo che nella Office Magna che si trova
So,
appena proprio all'uscita
the
potete
Office
trovare dei
Magna
colleghi che si occupano della pubblicazione del registro dei pazienti per l'emergency card.
will host,
Volevo parlarvi di un
the
progetto che
staff
si chiama
members telling you
Mentoring,
more
quindi
about the
progetto.
emergency card. And then I'm going to tell you something about the mentoring for inclusion.
È un
progetto che si occupa, si chiama Mentoring di qualità per l'inclusione
This deals
barriere condivise. È un progetto
a project about conclusion. It's co-funded by the European Union within the framework of Erasmus+. Parent Project is a partner in this, along with several associations in Croatia and Cyprus. The goal is to create a network that will develop a strategy of growth for young people that experience these barriers to become mentors for other young people who have the same problems throughout Europe. We're going to present this now because it's very relevant to what we were saying. So, older kids who've already overcome certain hurdles and who've developed coping strategies can share their experience with younger ones. Thank you for being with us at this round table, and I will now take some of you to the other room. Thank you.
Allora, siamo stranamente un pochino in anticipo, quindi siamo stati super bravissimi.
We are a little bit early for our next session. Before we begin with the scientific session, which follows this wonderful segment that you've just heard, I would like to invite Alessandra Barone from Italfarmaco to join us on stage because she's got an important message to share with all of you. Families, patients, doctors, clinicians, and so on and so forth. Thank you, Alessandra.
Grazie Fernanda.
Thank you, Fernanda. Good afternoon, everyone. I'm being told to go up on stage. I'm not a parent, and I'm not a doctor who sees your kids. But I am a doctor who, for about 20 years, has been working in pharmaceutical companies. And for the past 5 years, I've been dealing with Duchenne and Becker muscular dystrophy. And thanks to this choice, today I have the opportunity to work in Italfarmaco as medical medical officer for DMD for Italy, Greece, and Cyprus. And this has given me the opportunity to come into contact with Parent Project, which is magical because everyone is special in this association, but especially contact with them has enriched us enormously because through Parent Project, we in corporations and pharmaceuticals are learning about the needs of all kids and the needs of families as well. And even more importantly, this enables us to talk using the same language. It's a universal language, and so we want to make sure that everyone understands it at all different levels. So, why am I here today? Well, simply to bear witness to the importance of the project that was presented this morning. And I'm sure the Parent Project will remind you of it. And so my invitation is addressed to all colleagues who work inside pharmaceuticals to support this ongoing project in any way that they can, because this project, based on my experience, is allowing us from pharmaceuticals to feel like we are important members of the multidisciplinary teams involved in the DMD community. So, as Christina said this morning, please take another look at the leaflet that she handed out, but then move on from there. And Christina will tell you exactly what to do. Thank you. Thank you, Alessandra. Thank you from the bottom of my heart. Don't only look at the leaflet. I mean, of course, take a look, but then you can do one of several things. The first, which is the easiest thing to do today, is to fill out the form. Please complete it and hand it in, and it is for an ongoing contribution from your bank account. Secondly, we put on the tables the QR code. Here it is. And so this QR code will take you to the campaign website, and you can make a contribution through your credit card or through pen pal monthly or even annually. So let me just make sure that I'm doing things right. And let me add that when Jacopo spoke this morning, we were all greatly moved, but when we heard from Marco and Daniele.
Figli e anche perché hanno incontrato Parent Project subito.
Hire more. We want to increase the number of counseling centers throughout the country, and we want to work together with all pharmaceutical companies. But to do that, we need resources, financial resources, and if each one of you today decides to make a monthly donation of 30 euros, which is €1 a day, less than the price of a cup of coffee, if everybody were to, and if when you go home, you are able to talk to somebody and talk them into giving 30 euros a month, it means that we will have an additional 15,000 euros a month. So please do not leave here without making a donation to Parent Project. Enjoy the rest of the conference, and thank you, Alessandra and Dr. D'Amico, who is going to be speaking this afternoon. Move into the second scientific session, who agreed to present the studies. To join me, I invite Dr. Adele D'Amico, Lecco, and Dr. Federica Ricci from Turin.
Eccole, le vedo che ci raggiungono. Allora, mentre ci raggiungono...
As we wait for them to join us, could you please change my slide? Here we are. In this slide, you see that we're going to focus on approaches in the intermediate phase of development. And this morning, in the early session, we looked at a very initial phase. So approaches that left the laboratory not very long ago and that are gleaning initial findings in patients. And in this case, instead, we're going to move beyond that, and we're going to especially focus on clinical trials between phase 2 and phase 3. So more advanced trials that have already produced some findings, but we need to now check whether these results may be confirmed on a broader or wider population of patients. In the presentations, you'll hear speakers will talk about exon skipping strategies and gene therapy, but we will also be looking at strategies that do not try to restore dystrophin, but secondary defects, for example, fibrosis, inflammation, or muscle fragility.
Mattina con grazie agli interventi dei nostri...
We will hear from our 3 clinicians, who we'd like to thank very warmly, because not only do they work hard in the hospital, but it takes time to prepare the presentations. And that will be followed by a Q&A. So at the end of the presentations, I will ask the representatives from the very pharmaceutical companies to also step in, and you can ask questions. As this morning, you can ask them live by using the microphone, or you can also pose your questions on WhatsApp at the number shown. This is for those who are connected from home. Without further ado, I'd like to invite Dr. Adele D'Amico to join me, after which they will interact with each other. Thank you. Good afternoon, everyone. I'm Adele D'Amico, neuropediatrician at the Children's Hospital here in Rome. These are my disclosures. I'd like to show you or present you with the program of clinical trials for the gene therapy promoted by Pfizer. And we will look at some trials conducted and concluded. Some are still underway, and I will present the protocol without being able to show you the results. This morning, I think you were all here, so I'm not going to repeat things specifically. I'll just give you an idea of the concept of gene therapy. The first thing to learn is that all the constructs in gene therapy have very difficult names, more complex than the program itself. So Pfizer's construct has this name for the dystrogen MOVA Pamrevlumab. And this morning Stefano talked about dystrophin. So here we have a mini dystrophin, a dystrophin that has been deprived certain regions whose impact is less significant. So in order to be able to introduce this gene inside the viral cell, we create shorter genes that are lacking certain portions. The vector is a virus that was also used for other clinical trials and doesn't have a high immunogenicity, and then a muscle-specific promoter, which sees to it that the drug that we administer reaches the target organs, the muscle of the heart and the skeletal muscle. Then it gets inside the cell in the nucleus where it replicates so that that gene produces the protein without becoming part of the human genome. These are the trials, 3 conducted on patients. The first is on children. This trial has been concluded, and the other 2 are ones in which the subjects have already been recruited. It's already been conducted in Italy. They're not pharmacological only. The one has to do with the families of treated patients and what the likelihood it is for them to have antibodies against the virus, because we create a severe infection, and this may be useful if we have a treated sibling and one that is not, and that receives treatment. The second looks at the long-term efficacy of this drug. So all treated patients are observed in the long term to assess the durability, in other words, the time during which the drug is efficacious. This is the first study. It was conducted on children aged between 4 and 13 years of age, both ambulant and non-ambulant children. It was open, all were treated, and it was a phase 1 study which tried to assess tolerability and the safety of the drug. Obviously, we also look at other goals, for example, the expression of dystrophin on the muscle and efficacy. But the primary goal of the study, because it was open on a small number of patients, was to check the safety and tolerability. We recruited, on the whole, 21 children. 19 were aged between 4 and 12 years and could walk, and 3 children instead did not. This study also shows us the best phase. The first children received a low dose, and then after that, they were administered a higher dose. They received a baseline treatment on 0 day after having received pre-medication with high-dose corticosteroids to reduce adverse events related to the immunogenicity that's triggered. We do an assessment at 1 year, and then over time, in these children, we did muscle biopsies to check the expression of dystrophin, 1 at time 0, 1 at 6 months, 1 after year 1, and then as an option after 5 years. This the trial aimed to look at safety. So these were the outcomes, adverse events, and how the drug was tolerated. There are common adverse events which were present in most children. So after infusing the drug, most of these children experienced vomiting, nausea, fever, which is a little bit like the flu because it's conveyed through a viral vector. And some children had severe adverse events which can jeopardize the survival of the child. In this case, you see that there were cases of thrombocytopenia in 47% of the patients who were treated, and especially only in patients treated with high doses, acute renal failure in one. But anyway, it's important to say that all of these adverse events, even the serious ones, were resolved 15 days after the initial infusion. As regards efficacy, this is still in an exploration phase because we had a few children. We didn't have a control group. As a control group, actually, we used children whose results we have because of their natural history. So we try to find children in the patient registries who had the same kind of clinical characteristics. And then what we saw in treated children was that children gained motor ability with the North Star scale. I think most of you are familiar with that. And they had a gain of 2 points. If we looked at the children, the older versus the younger, the gain was greater in the younger children. All of these findings need to be interpreted cautiously. First of all, because efficacy should be assessed 2 years after administration. The problem of not having an open or a control study is big, because if you have an open trial, it is significant. In controlled clinical trials, it's always important to have some kind of placebo control within the trial itself. This instead is the Cifreo study, which you probably are familiar with because it came to Italy. It was conducted in several Italian hospitals, including Bambino, Gesù, and Policlinico Gemelli. This is a final stage. Initially, it was clarified that the drug was acceptable from the point of view of safety, but then there was another double-blind study with a placebo that was done. All children at the end of the study will take the drug, but there is a transition from one cohort to the other. In other words, in the first year, 2 children out of 3 receive the drug, and 1 out of 3 receives placebo. And in the first year, all children are subjected to the same kind of procedures and withdrawals. At the end of the first year, there's a second infusion. So those children that took placebo will take the drug, and the other way around. It's in double blind, which means that we do not know who takes the drug and who takes the placebo, and neither does the family. The inclusion criteria were children between 4 and 8 years. Excluded were children with some mutations in some exons. And during the trial, at one point, the inclusion criteria were modified, and excluded were children who had alterations in another district of the dystrophin. After 2 years, so there's an infusion first year, the second year is observation, and that's followed by 3 additional years of long-term observation. Enrollment has been closed, but the study is already underway, so not all children have completed their year of treatment, so we don't have results that we can show you. This is a third study with the same molecule. It is not underway in Italy. It involves young children. With the same compound, the authors are trying to test the tolerability in a population of young children aged between 2 and 4. In this case, again, the child is in open, so there's no placebo group because the main goal is to test the safety. And children, once again, receive IV infusion of the drug. They have 3 muscle biopsies because the expression of dystrophin is a secondary goal. So at 1, 2, and 12 months. That follows, I'm sorry, a 4-year observation period follows that. Let's change subject completely. I was asked to present 2 completely different molecules. This is a drug that exerts its action on the heart. So I may not be completely capable of answering questions you might have. This molecule is called Ifetroban. Fernanda told you that we would have discussed molecules or drugs that restore the protein, as well as those that act on secondary mechanisms. So this is a drug that acts on the secondary mechanism. Ifetroban is an agonist of the thromboxane receptor, which means that when there is no dystrophin in the muscle cells, there is an alteration of the number of proteins that are on the membrane, but inside the muscle cell as well. And they can alter their function because they might be localized in a different place. LNOS is one of them. We know that its location changes when there's an absence of dystrophin, and it's an important molecule to prevent oxidation stress. So when we have an absence of dystrophin and the LNOx is located or changes location, among the various phenomena, we have an increase in oxidation stress, which leads to the production of thromboxane, which causes inflammation at the muscle level. The thromboxane inhibition has also been indicated in cardiac pathologies. What happens here is that this compound blocks the effect of thromboxane, and therefore it prevents inflammation and fibrosis in the heart tissue. Safety studies had been conducted previously in healthy volunteers and in heart patients, so this is a phase 2 trial. I think maybe last year you'd already been presented with this, the initial phase. The study looks at the efficacy, pharmacokinetics, and the safety of the molecule. This study is for Duchenne patients that have dilative cardiomyopathy. There's a division in 3 groups. Patients are split up in 3 groups. So one takes placebo, one takes a compound at a low dose, and the third group takes a high dose of the molecule. In each group, patients are divided between patients that have a reduced ventricular function above 45%. In the second group, we have patients with a more advanced phase of the ventricular function and an ejection fraction between 35% and 45. The first group was enrolled in 2020, so sometimes it takes a long time to enroll patients. To December 2023, the first cohort was visited after 12 months. The first cohort included patients with a less severe heart condition, whereas by the end of 2024, patients with a more severe cardiomyopathy will have been observed. So all I can show you is the clinical features of the 25 patients that to date have concluded 6 months of treatment. More or less, we have a target of about 50%. The trial design provides for the enrollment of 16 patients per group. Here we have 9 patients for the first group, I'm sorry, for the group with high doses, and 8 patients each for the other 2 groups. Now the observations are at 6 months. Here are the characteristics. We have ambulatory patients, non-ambulatory patients. In the high-dose patient, there is a higher percentage of patients that are non-ambulatory compared to the others. Some need ventilation support, and here there's a distribution according to the stage of the disease. And this indicates whether or not patients took steroids. With regard to safety, a lot of these patients presented adverse events. We're talking about a patient populations with a more advanced muscular dystrophy with ventricular dysfunction. So even in the placebo group, adverse events were reported. They're not related to the drug in this case. Severe adverse events which required exiting the study concerned 1 patient who had taken placebo. And these are the most common adverse events that may not necessarily be related to the drug: nausea, vomiting, viral infections, etc. Conclusions. Both regimes were well tolerated by patients. There are no great differences between patients treated with a high dose or those with a low dose. The patients will be observed all the way up until 2024. And with the cohort of patients with a more advanced stage of the disease, the enlisting is still open. Thank you very much, and now I'd like to give the floor to the next speaker.
Grazie. Ah, questo, ok, va bene. Ci sono le mie slide? Ok, va bene, perfetto. Allora, io parlerò di 2...
I'm going to talk about 2 molecules that are in their intermediate phase of development, namely phase 2 and phase 3 is now starting. And then we have another molecule, ATL1102, that is still at a bit earlier phase. Anyway, both studies have not reached Europe yet. Capricorn Therapeutics is the one supporting the first study. The second one, it's Percheron Therapeutics. Antisense Therapeutics was its earlier name, and it is based in Australia. So let's try to start with Capricorn. The Capricorn study, I wish to thank them for allowing me to use the slides. They are in English, but I will go through them in Italian, of course. So anyway, these studies have a beautiful name. The name is Hope. Of course, it means a lot to all of us, but the working group behind it was basically about the possible restoration of the heart function. So the idea behind this study is a possible treatment of cardiomyopathy. As you all know, this is something that is typical of both DMD and BMD persons at different stages, of course, but they normally go with these patients being late or not late ambulatory. So we use cells that are progenitors of cardiac cells known as cardiospheres, extracted from organ donors. They are engineered and then injected. Well, these cells have nothing to do with stem cells. I must stress that, because once they are injected, they deliver cytokines, growth factors, or exosomes into the relevant tissues, and then they are simply done away with. So the engraftment is not does not really take place. So let's start with the first study, which is a phase 1 study regarding 25 DMD non-ambulatory patients whose ejection fraction was over 35%. Those of you who have been part of clinical trials very well know that here the request is usually around 45-50%. In this specific case, the value requested was lower because the target was indeed the heart. And actually, during this first phase, aimed at detecting the safety profile of the molecule, had as a secondary outcome to evaluate the efficacy of the cardiac fibrosis reduction. Now, the study was quite successful and has allowed for a second phase where the focus was extended to the PUL, the performance of the upper limb. It's a scale, as you may know, that is being very frequently, very often used as an outcome measure, since we know that, luckily enough, many clinical trials now orbit around very young boys, as well as boys who are losing their ambulatory function in order to preserve. So the aim is to preserve the function of the upper limb. So let's try to talk about now HOPE-2. HOPE-2 focuses an even more restricted group of people, so DMD, non-ambulatory patients, and the heart function was a bit higher than the previous one, between 45 and 50%. Well, the phase 1 considered the use of an intracoronary injection, so it was quite an aggressive approach, whereas now we have an intravenous injection to be administered every 3 months. And this has provided with a very interesting piece of data, because as you can see on in the graph on your right-hand side, the cardiac function seems to stay the same over 1 year, and remarkable benefit for what pertained to the mid-level PUL, where the declining function after 12 months was much lower than the one observed in the group that did not receive the investigational molecule. So that was a good result, already. And therefore, an open-label study was a study where, as you know, the placebo control group randomization is out of the study, so that all participants are administered the investigational product. That went on for quite a long time and allowed us to witness a certain, somehow slower decline in in what we were supposed to see even after 2 years. So, if considered as a whole, the benefit was perceived as being particularly meaningful, especially further to this graph, where, as you can see, those who were always given the therapy showed a given decline, and those who started being administered the drug during the open label phase still kept some stability, which is a statistically significant piece of data. And also within the heart, what was previously observed has been confirmed. These are graphs we are all familiar with, since unfortunately we know only too well that DMD patients all show such a declining cardiac function. Well, here we see that further to treatment after less than 1 year with cardiospheres, although the population is quite limited, only 9 patients, well, some trend to stability was obvious. And such statistical significance seemed to be even higher for the upper limbs than the heart, further the intravenous, after the intravenous injection. So now a larger trial is going to be started soon. It's called HOPE 3. Here we have 58 patients, so a much larger cohort than in the 2 previous studies. And I mean, you can read here even the the secondary endpoints. Now the recruiting has been completed. We are now carrying out an interim analysis, and we'll see what the developments will be, namely as to the possible extension to a larger cohort and more centers. So this is perceived by the companies themselves as the possibility of delivering a therapy based on the employment of these cardiospheres. So a therapy that, in the absence of something particularly significant, may even go hand in hand with other therapies, basically the gene therapies that we are familiar with and that are being widely considered. So this is not a real molecule. It's basically a group of cells that deliver some substances apparently able to improve the well-being of the muscle. Now, what about the second molecule we considered at first, the ATL1102? That's the pipeline of the company. Its name has changed, as I said, into Percheron Therapeutics. So we are in the advanced phase of this study, although this particular molecule has also been widely studied for multiple sclerosis. And the reason why I'm saying this is that this is a molecule whose aims are anti-inflammatory, different from steroids, able to fight against the inflammatory process that takes place within the muscles, whereby cells growth is accelerated through the chronic process that is activated during the cell contraction. Now, 75 subjects with DMD have been considered in particular in order to find a a lymphocyte subpopulation that seemed to be quantitatively larger in those boys with a definite phenotype, namely a mild phenotype. So the suggestion was that this could be a good starting point for the purpose of stratifying the patients, also in other studies. Anyway, what the company suggested is that such CD49 could indeed play a role. So since the AONs had been previously studied and their synthesis had been blocked on the lymphocyte wall, they suggested this construct should be used to reduce the inflammatory process of the relevant cells, whereby to provide the muscle with some more stability and to make the progression of the disease somewhat slower. So an animal model was used at first, then the phase 2 study was started and it's been recently published, carried out on non-ambulatory DMD patients, only 9 of them, only in Australia. Now they seem to be reaching out to the US too. So ATL 1102 is the antisense oligonucleotide that was injected subcutaneously for 8 weeks. The tolerance and safety were considered, and among the secondary endpoints, we recall at this stage the change in the phenotype and some functional changes. Now, the observation was about the large amount of side effects, over 100. However, there were basically skin rash because of the subcutaneous injection. So, I mean, not particularly relevant side effects at all, basically, meaningless. So safety at 24 weeks was definitely tested and confirmed. Otherwise, no other dramatic changes were observed, and some particularly interesting data, on the other hand, were observed, namely regarding although in the absence of statistical significance, regarding PUL, the performance of the upper limbs, and the myogrip. So, strangely enough, we did not see any particular changes that were expected, I might add, regarding the lymphocytes, which showed, which seemed to be quite, which seemed to improve the stability of the upper limbs, whereby to allow a disabled boy to get a better quality of life. So now a double-blind phase is getting started. Recruiting has just started. There is going to be a placebo group, and then 2 different groups with 2 different dosages. Right now, the study, as I said before, I mean, still stays in Australia with a possible reaching out to the US, but it's quite promising in any case. Thank you very much. Of course, there's still a long way to go, but we need to go all through it together. I mean, you and the companies. Thank you.
Buon pomeriggio a tutte e a tutti, in attesa della presentazione.
Good afternoon. I'd like to thank Fernanda and the big family of Parent Project for the invitation. I'd like to talk to you about two additional molecules in the intermediate developmental phase. These are the two molecules that I'm going to talk about. Let's start with SRP-5051. You've already heard about exon skipping. You heard this morning the use of short sequences of nucleic acids called antisense oligonucleotides that bind to specific regions of pre-mRNA to induce the skipping of one or more exons during the processing of mRNA. In this case, the skipping of exon 51. Today, I will present you with some results issued recently, just last week, from the Momentum study. This is a phase 2 open-label, non-randomized, two-part dose expansion study. Part A had to determine the dose to then take to Part B, and one part was devoted to studying safety and tolerability, and Part B is devoted to safety, but with efficacy, which was a continuation of Part A, so with more more cases. Part B included patients who had finished Part A and patients who were treatment naive. 40 patients were enlisted in Part B, 50% ambulant, 50% non-ambulant. The age was between 8 and 21 years in the US, Canada, and Europe, including Italy and Turin. The primary outcome was change vis-a-vis the base level of the dystrophin protein level at week 28. Secondary outcomes included variation of exon skipping and the variation of the PDPF at week 28 and the incidence of adverse events related to the therapy. We had 40 naive patients and patients that came from Part A for a total of 62 patients. We studied two doses that were administered every 4 weeks. The study is still underway. There was a high dose and a low dose. So the high dose was 30 milligrams, the low dose 20 milligrams. During the study, all patients were asked to take everyday magnesium as a supplement to try to reduce the main side effect of which we will look at later, which is low magnesium levels, and the dose was adjusted. These are the top-line results issued by the company at week 28. So these were the defined outcomes. In red, patients with the low dose, and blue, those with a high dose. We also have a comparison with the molecule authorized in the US. With regard to the baseline, there was an increase in the expression of dystrophin and a 4-fold increase for the low dose and 12-fold for the high dose, and this is statistically significant in both cases. We have the patients on the whole. The increased production in dystrophin was similar in both patients cohorts. With regard to the secondary outcomes, there was an increase in the amount of exon skipping with regard to both the high and the low, and an increase in positive fibers, the expression of dystrophin twice for low dose and about 5 times more for the high dose. Before the conclusions, it's important in this study to talk about safety. So the side effects, the percentage of side effect reporting concerned pretty much all the patients enrolled in the study. The main side effects were hypomagnesemia and hypokalemia, which means the low levels of magnesium and potassium, respectively. And with fewer cases, clinical signs like nausea, vomiting, basically these two, and renal function in the lab. As regards the side or adverse effects, a small percentage was considered to be severe because it demanded the hospitalization of patients and management in a hospital. So severe side effects concerned low magnesium and low potassium levels, but none of the patients had to discontinue the treatment because of these side effects, and that's to be borne in mind. In conclusion, first of all, it's important to specify that right now, Sarepta therapies have not been authorized in Italy or in Europe. The momentum study, which I just presented here on SRP 5051, is in 2 parts and is still underway, and it looks at the safety and efficacy of therapy in patients with exon skipping, 51 exon. And the primary endpoint was reached and the secondary endpoints were also favorable or positive. For example, the increased exon skipping and the percentage of fibers positive for dystrophin. The most common adverse event correlated with treatment was low magnesium, and this had implications on the continuation of the study. There is the need, of course, to supplement with magnesium and adjust the dose. The second molecule I'd like to introduce, and here we're talking about the location of the damage, the muscle cells. The molecule is EDG-5056 by Edgewise. The target is myosin in quick contraction fibers in DMD patients and Duchenne patients. I'm sorry, and Becker patients. Maybe you know these concepts already, but I'll repeat them anyway. The approach is to protect muscle fibers more susceptible to damage because of contraction. And that's because some muscle fibers are more susceptible to this damage in the absence of dystrophin. This therapy is experimental, and it was designed to protect these more sensitive muscle fibers, and it acts independently of the mutation caused by the disease. In animal models, preclinically, this molecule has proven to be able to protect these fibers and mitigate the development of long-term damage. Very quickly, the protein complex and the protein complex associated with dystrophin has several functions, the main which is to prevent lesions in contraction fibers. It works like a shock absorber. That happens especially in rapid contraction fibers in red, which are stimulated more during the contraction movement. So in the absence of dystrophin, these fibers receive more damage, are subjected to more damage during contraction. When a muscle fiber cell is damaged, then it releases outside of the cell in the bloodstream molecules which we call biomarkers because we use them to identify muscle damage. So it releases proteins that point to muscle damage. One is CK, which we know very well, which we use in clinical practice, and then we have others like troponin, for example, which is released by quick or rapid contraction fibers. This is the image. This is a damage that, sorry about that. I was waiting for the video. So these are the preclinical trials which supported the hypothesis according to which the therapy would have a protective effect. I wonder if you could start the video because I can't do it from here. The idea is to show you how the contraction on the fiber cell of the fiber is visible in the absence of dystrophin. I'm sorry, I just can't get the video to start. And it shows how the EDG-5506 molecule on the same muscle fiber plays a protective role. I won't show you the whole video, but it's obvious to see the damage accumulated in the fiber not containing dystrophin. So this is the preclinical evidence of the efficacy of this experimental therapy. With regard to clinical development, a phase 1 study was carried out in healthy adults and adults with Becker Muscular Dystrophy, which then led to the ARCH, open-label study in Becker Muscular Dystrophy patients. We've already discussed that. These are just a couple of slides to show you some findings, although many of you have already seen them. This showed a statistically significant reduction in biomarkers of muscle damage after 12 months of treatment. And again, in this study, it was observed using the North Star scale that there is a tendency towards improvement, and the trend is different to the natural history of the pathology, which describes a decrease of about 1 or 2 points per year. So the patients who were included in the study showed a different trend with a trend towards improvement. These findings opened the door to the subsequent steps for the development of the molecule that we're talking about, both in the Becker muscular dystrophy with a phase 2 study in adults and adolescents, and in Duchenne with 2 studies, Lynx and Fox, for children with DMD, and Fox is in children with DMD already treated with gene therapy. Both are phase 2 studies. Lynx is a study in 2 parts of the duration of a year to look at the dose and the safety of the molecule for subsequent studies. Assessments and visits planned are about 10 in the course of a year. They provide for clinical and instrumental tests and motor tests to check on the safety of the molecule and the functional outcome in these patients. In conclusion, for EDG-5506 molecule by Edgewise, this is an oral molecule which is destined to preserve and improve function in patients with D and Becker and Duchenne with any mutation, and it acts at the level of muscle cells. Those are most sensitive to damage. The potential is for it to be used on its own or together with other therapeutic approaches for dystrophies. I'd like to thank you for your attention, and I'd like to thank the pharmaceutical companies for having provided me with these very useful slides. Thank you to the patients, families, clinical centers, associations. I'd like to thank patients and families not just for their commitment in clinical trials, which don't really represent the reality, but for the commitment they make in always trying to improve in their personal development. Thank you, everyone.
Allora, ringraziamo ancora tantissimo le nostre.
Well, thank you very much. I would like to thank you all also for keeping the time schedule. And now let me ask the company representatives to come join us here to the podium. By the way, questions may be asked simply by raising your hand. Ilaria and Francesca are in the hall ready to come get you with a microphone, so to speak, or you may want to write them down using the WhatsApp number that you'll soon watch on the screen. So, very good. So I get here representatives from Pfizer, Sarepta, John Donovan too, from Edgewise, and there are 3 more companies whose representatives are with us online. Ingrid Anderson from Cumberland, from the US, Mark Awedal from Capricorn, and James Kerner from Percheron Therapeutics from Australia. We are in the middle of the night out there, I believe. So thank you very much for being so willing to join us. Ilaria, any questions? Yes, there are some questions. Let me start with question number 1 for Pfizer. From Daniele, from Gaeta, Southern Italy, about cardiac adverse effects. What is their etiopathogenesis? And question number 2, beside the adverse events behind the stop of the phase 3 study last year, what about the fact that some patients have been ruled out in the meantime, and have any other adverse events been seen? And if so, what about their etiopathogenesis? Thank you.
For you.
The representative from Silvina.
Okay. Thank you. Hi, good afternoon. My name is Silvina Gallo, and I work for Pfizer. I'm a medical doctor, and I'm the clinician managing the phase 3 study, CIFRA. So I think the first question was about our cardiac adverse events and what is the reason behind them. And to put it simple, we see 2 types of adverse events. The first ones occur quite early after the infusion of the therapy, and they are considered to be related to an immune response to the viral capsid that transports the gene compound. And that is also supported by the fact that they seem to respond very well to immunosuppression treatment, mainly with high doses of steroids. We also see cardiac events later on, usually after the first month post-treatment. And again, these adverse events are considered to be also due to an immune response, although in this case, the target is considered to be not the viral capsid at this point, but rather the transgene mini-dystrophin protein that has had time to be created. And this is linked, I think, with the second question that asks why some patients have to be excluded. And this is in relation to these responses against the transgene protein. We have learned, with the help of internal and external experts and also colleagues in other pharmaceutical companies, that when patients have mutations that prevent them from building parts of the protein that then we give them, that causes them to have or not to have immunotolerance to certain parts of the protein. Basically, that means that the immune system has never seen anything like parts of the protein they create after the gene therapy. And so that immune system thinks, okay, I'm seeing something that is very strange, it may be dangerous, and tries to destroy it. And this is considered to be related, like I said, to these specific mutations that the patient have that make them some parts of the transgene protein exchange. And so during the development, to be really, really safe, we have decided to exclude patients who could potentially be in this group.
Grazie.
I have a question for Sarepta. Ilker from Turkey. It's in English, so I will read it out in English.
Started with exon 51 skipping and then followed by 53 and 45. What is the roadmap for PPMO? Any estimated dates to start human trials for 53 and 45 or other exons?
Hello? Okay, thank you for the question, and thank you to Parent Project for the invitation today. My name is Rachel Salazar. I'm with Sarepta Therapeutics, and I appreciate the question on our PPMO program. So as you clearly presented today, that first program is for 51 skipping. And so our plan is to have a conversation with the FDA Q3 of this year. And based on that conversation, we'll consider future programs.
Grazie mille.
Ci sono tante domande.
Sì, immagino.
Domanda per Capricorn.
Here's another question for Capricorn. So two people would like to know when CIP 1002 will reach Italy, also in younger patients. And then to better evaluate the efficacy of the trials, should boys be taken, should cortisone taken off the boys before actually admitting them to the trial? And then there's another question that has been written down maybe, or no, actually here is the answer from Capricorn.
It's fine, we can hear you, and you don't have the translation? Okay.
Okay.
When can we see the HOPE-3, the CAP 1002 on little boys and in Italy, hopefully? And then the other question was if it is not appropriate to exclude corticosteroid usage to make sure that what we see is due to the treatment and not to the steroid.
That's a very good question. Thank you. So in order to get into the trial, corticosteroid treatment has to be stable for at least a year. So the patients have to be on corticosteroids for at least a year, and there have, before starting the trial, that there's no changes in steroid use for 6 months prior to entering the trial. So any benefits that we would see over time over the course of the year would be attributed to CAP-1002. So that is that. Your first question with regards to when can we see CAP-1002 in Italy? Currently, the clinical trial is only in the US, and we are currently trying to make plans to see with some of the EMA regulatory authorities what is the best path to take for a clinical trial in Europe. So we are still investigating that, but no plans have been defined to date.
Grazie mille. C'era un'altra domanda per quanto riguardava, se non ricordo male.
Another question for Sarepta, I believe, regarding the possibility of home dosing. Can home dosing take place?
Thank you for the...
Can it be used?
Hello? Okay, thank you for the question. And so it's a great question, especially in thinking about the families that are participating in this study. And with the PPMO program that you presented, it is monthly dosing, right? And so the burden of coming into the clinic on that monthly dose. And so I think when we think about any clinical trial, first we have to establish the safety and then move on into that more of that home dosing that is an option currently for PMO dosing depending on the country that you're in. So I think there's not only site requirements, hospital requirements, safety requirements, country requirements when it comes to getting to that home dosing. But understood, and I'm happy to pass off.
Sì, io vorrei solo...
I would just like to say that when it comes to home dosing, whether the product is investigational or not, there are some issues to be considered. First of all, the size of the company, and then the size of the hospital, the local hospital or the country hospital where the administration takes place. In our region right now, it seems like it is quite a common experience that the pathway is very complicated, and we do not seem to have made it yet. Let me be clear, and frank about it. Ilaria, so 2 questions for Edgewise. Number 1, what is the mechanism of action of the drug and what is its target? And question number 2, has any effect been seen about the inflammatory state?
Yes, thank you for those questions. My name is Joanne Donovan from Edgewise. And the first question is, what is the target? And the target is fast myosin. So it is the type of myosin. We have 2 types, fast and slow, and it's the fast myosin, the contraction protein. What it does is it takes the edge off the contraction in a way that it prevents then damage, the kind of contraction-induced damage that is the fundamental problem when you don't have dystrophin. So by decreasing that even by 10%, as you saw in the video, you completely protect the muscle from any visual damage. And that's what we are looking for in the boys with Duchenne. And we have seen, at least in terms of biomarkers of muscle damage, we've seen reductions in Becker Muscular Dystrophy. So that's the target, and that's how it works. Did I get both of those questions? Okay.
Una domanda per...
One question for Percheron. Can you hear English translation? Can you hear English translation? Okay. Someone says they do. Okay. So is translation okay? Is English translation okay?
Allora, questa mattina abbiamo...
Okay, so this morning, we heard some people talk about the new generation antisense that can be administered for over 1 week. Can we do something about the chemistry of the molecule so as to increase the time between 2 administrations?
Thanks for the question. I'm James Guy from Percheron Therapeutics. And look, I think the question is a good one. The pharmacokinetics of these drugs is challenging, and they typically require frequent administration. Our drug is not targeting dystrophin, it's targeting the immune system, it's targeting a population of white blood cells. And for that reason, we require at the moment quite frequent administration. At the moment, it's a weekly dosing schedule. We are looking at ways that we might be able to extend that to 2 weeks, even 4 weeks, for example, by adding pegylation to the molecule or things of that sort that will allow it to remain longer in the system. But at the moment, it's a weekly administration, but we want ways to extend that.
E prima di leggerne altre, magari sentiamo se c'è
Would anybody else like to take the floor from the audience? Any other questions? Otherwise, I have some other questions here in the WhatsApp chat. Okay, there's someone raising his or her hand.
Salve.
Hello. It's for Pfizer. I understand you are studying this therapy we're now familiar with, namely focusing on AAV9 vector. I understand. Now, if this is fine, maybe in the near future you will be able to go back to the first patients, those patients who were first injected, namely finding another carrier so as to produce more dystrophin?
Thank you. That's an excellent question. And it's a bit early to tell. As you might know, we are we've been running for some years now our phase 3 study for gene therapy, a randomized placebo-controlled study. And we are getting close to the time when we can conduct a final analysis that hopefully will allow us to discuss with regulators the possibility of register this treatment. Once we are able to see the results of this study, all the other possibilities, all the other populations, all the other therapeutic modalities will definitely be back to be discussed. But unfortunately, I would love to, but I cannot give you a definitive answer now. It's early days in that sense. Thank you.
Grazie Silvina. Ilaria?
Andiamo con un'altra domanda.
One more question for Capricorn. And it regards trial hope. In the placebo group, we see a decline in the ejection fraction from 50 to 10% in a 12-month period. Is that right? And if that is the case, shouldn't we consider this pathway as not typical of a DMD boy, in which is possibly present in the placebo group?
Non credo che tu non... Forse dobbiamo tradurre. Marco, do you hear the question?
Mark?
Italian.
I only heard it in Italian.
Okay. So Ilaria, you have to translate it, please. It's very long, but maybe she can summarize.
Okay, in the placebo group, in the slide that it was shown before, the decline of the ejection fraction went from 50 to 10% in 12 months. And he was wondering if this is correct, because this doesn't look like a typical trajectory for a Duchenne patient. And if any possible bias have been taken into account, maybe more serious for the placebo group.
Yes, so that's not exactly how to interpret that graph. So that graph shows an analysis, a ranked analysis of which essentially what happened is over the course of the first year, the difference between
We can't hear you very well. Non si sente benissimo.
For exos.
No, scusate, non so se non sento.
So the point is not about the LVEF percentage on the x-axis. We were talking about the scores with variations of plus and minus 5. So that's why the variation was about 10 points, but not 40.
Di nuovo per Edgeways, è scritta in inglese, quindi di nuovo. Same degree of disease stability at 12 months in Duchenne as seen in Becker. Will the lack of dystrophy in DMD reduce the effect?
So that's a good question, because it is a different situation in that you have some dystrophin in Becker. And so that is why we are doing the phase 2 study, which is a dose-ranging study to look at biomarkers in response to different doses in boys with Duchenne, so that we have the right dose for a phase 3 study. The other question that I realized I didn't answer before was about inflammatory markers. And we see right away that the markers of muscle damage go down within a month or so. What we see in the patients with Becker is that over a period of more like 6 months, you see the inflammatory markers go down, the fibrotic markers. So there is a gradual transition in response to decreasing the damage to the muscle. The muscle gradually moves to a profile closer to normal.
Grazie Joan. C'era una domanda per Cumberland, ma non li vedo più.
There was another question for someone who was online. So here you are. So this is for Ingrid. And the question for Ingrid is the following about the recruiting. Well, apparently recruiting is still going on for the Ifetroban study. Are you considering the possibility of involving centers outside of the US? So, for example, in Europe, and why not in Italy?
Thank you for your question. If we do proceed with phase 3 development, we will open an additional countries, including countries in Europe.
Ok.
E abbiamo un'altra domanda per Pfizer.
And one more question for Pfizer.
Study with the Pfizer molecule, is it still open for enrollment somewhere in EU, in Europe?
Unfortunately, well, it's good and it's not good. It's not open for enrollment, which means that some families are left out. But the good thing is that that means that the study, both the phase 2 and the phase 3, are fully enrolled, which get us closer to being able to assess the safety and the efficacy. And the phase, for those of you who are not aware, the phase 3 study has sites, doctors and patients in Italy. So we are very happy about that.
Siamo vicini all'orario del coffee break, ce ne sono, finiamo qui e proviamo a fare.
So we are almost ready for the coffee break. I would also like to thank the people who have been here with us on stage, and of course the representatives from our own group here in Italy. Thank you very much. Thank you.
Prima di dichiarare aperto il coffee break, come dici? Ok, prima di dichiarare aperto il coffee break.
Okay. A few announcements before coffee break. So At 5:15, the Sala Leptis will host the relevant session. And then at 5, 3 different lab sessions will be held. Mindfulness only for parents in the Pergamo Hall. Drones for the boys at 5:30. And then again at 5:30, Orange One will host a special lab with pets. Thank you. Thank you. Enjoy your coffee. But we might have some surprise. I'm not sure.
Vado. Should I go?
Vai Ilaria. Buon pomeriggio, bentornati.
Good afternoon, welcome back. I'm extremely happy, we all are, to have Amico with us, who's going to present this next session. Amico is a professor of genetics at the University of Leiden, and she's actually a guru when it comes to research in DMD. She's also an exceptional blogger, well known in that environment. She's also the queen of origami, apparently. I'd like to call her to join me on stage to introduce the session, as well as our guests, who I'd like to thank for being here.
E vi ricordo agli oratori di parlare piano.
I'd like to remind speakers to please speak slowly enough to enable the interpreters to do a good job. I thank them once again. And I also would like to remind you of the WhatsApp number. You can post your questions in the chat there. We already had one question on gene editing. We can pose it again. Thank you.
Okay, thank you very much, Ilaria, and also already thanks in advance for helping me with the WhatsApp questions and translating and reading them so they can be translated. So welcome to this session on preclinical research and the future. So why do we need preclinical research when the whole day you have heard about clinical trials ongoing, early stage, late stage? Well, we need this because not everything that is in trials will succeed. Some trials will fail. And also not everything that succeeds will be perfect. So even when something is approved, there's often room for improvement. So therefore it's needed that we have a continuous supply of new therapeutic approaches, but also when things fail, often it's because the models are not optimal. So we need new models as well that are then hopefully more predictive. So what we will have, we have 3 talks, 2 of 15 minutes, 1 of 20 minutes, and please keep your questions coming, the questions we do at the end, put them in the WhatsApp. Also, don't be afraid to wave if you want to ask them at the moment. And this is a scientific session. All speakers will try to explain things in a way that you can understand, but don't be afraid if you don't understand. Don't be afraid to ask for an extra explanation, because the scientists, we are trained for 8, 10, sometimes even more years to get the information that, and the expertise that we need. So the fact that you don't understand without all this training, that doesn't mean that you're not intelligent. It just means that you didn't have the training. So don't be afraid to ask. With that, I'm going to introduce the first person, which is Saverio Tedesco from London, originally from Italy, and he will present on 3D muscle bundle models and the MAGIC project, and that's why he gets 20 minutes, because he presents on 2 things. And the 3D muscles, you may know of them as muscle on a chip. These are models that allow us to use human cells to study muscle-like contexts instead of the mouse, which is of course not a mini human. So it's now possible to do things that we wanted to do for a long time but couldn't. So I look forward to Saverio's talk. And Saverio, if you see me stand up, that is your sign to wrap up. So the floor is yours.
Thank you very much, Amico. Thank you to Ilaria and the entire Parent Project team for the kind invitation. Do I need to do something? Yeah, that's it, great. Let me try to familiarize quickly with the pointer, and this is how I point. Fantastic. So, as Amico said, I will be spending a few minutes. Why do I speak English? He's right. You're right. It's just the default. Ok. Riniziamo in italiano. Scusatemi, ma dopo 12 anni nel Regno Unito, questo è il...
I'm sorry, 12 years in the UK, it'll do it to you. And I probably will make that mistake later on. So please wave at me in case I do. So, obviously, You're all more than accustomed to hearing about muscle at this meeting, but I just wanted to give you some snippets, if you like, some short information to contextualize my talk. We know that the muscle is the most abundant human tissue, and it has quite a complex structure and functions as motion and muscle pathologies like Duchenne muscular dystrophy are difficult to treat. Something that we often overlook is that we have different types of muscle pathologies and different types of muscular dystrophies that are characterized by proteins which don't work and don't function properly in different districts of the muscle, the nucleus of the cell, all the way to the matrix that we find around muscle fibers. It is crucial to understand the pathological mechanisms in order to develop efficacious therapies. We've already heard quickly the pros and cons of certain animal models, and this is something that we're going to go further into later on in this session. And the use of bioptic cells is not an easy task because we make fewer muscle biopsies, and sometimes the cells may not behave appropriately after spending several days or quite a bit of time in culture in the lab. So that's why my group and others in the past decade have tried to develop human models, humanized, if you like, models of muscle diseases, including DMD, to generate a sort of avatar, if you like, a sort of lab patient. And we want these models to be tailored to be specific to the type of disease or mutation. For example, we want to be given the opportunity to study the mechanism of the disease in a longitudinal way over time. And we want them to be flexible because we want to have the opportunity to study molecular mechanisms and see how they behave, not just in the molecules, but how the entire tissue behaves during the evolution of the disease. A solution comes from the use of human stem cells, pluripotent induced stem cells. I'm not going to go into great detail because I'm sure that many of you have already heard about them. This is the Nobel laureate for medicine. The concept here is rather simple. You take a somatic cell, one from the blood or the skin, you provide it with a cocktail of molecules that enable it to go back, if you like, in time and become very plastic, so that with the appropriate protocol, we can retarget them towards the cell type that we're interested in. In our case, it's a muscle. This way, we have an unlimited wealth of specific cells in the patient to do our studies. Now, these have to also reconstruct the complexity of the muscle in the lab, so they can't just recreate a thin stratum of muscle cells because that wouldn't reflect the complexity of the muscle in the human patient. And it is for this reason that we have spent quite a long time in the past 7 to 8 years to move from a bidimensional model to a three-dimensional one in order to create human artificial muscles from these iPSC cells that provide us with abundant material to create the tissue, but also give us the opportunity to generate not just muscles from those stem cells, but other cell types that are essential, like motor neurons, the innervation to the muscle being involved, and muscle cells, which combined with biomaterials make it possible for us to form these structures in the laboratory to carry out more in-depth studies, at least more in-depth than those we used to carry out a few years back. This is work that we published in recent years, and perhaps some of you have heard about similar systems from other groups. There is a different nomenclature People call them organoids, engineered muscles, artificial muscles. These are just variations on the theme. Just to give you an idea, here in this video, you will see a 3D reconstruction of the muscle fibers outside of the muscle. They are external, and these are formed in about 7 days of differentiation. In green, the titin muscle cells. In red, the expression of dystrophin, which you all know what that's about. And the interesting idea is to start from the poles, the nuclei of these structures. One of the advantages to doing iPSC cells is that we can create networks of blood vessels and motor neurons. These are ones that we combine with other cell types like fibers, vessel cells, all of these coming from the same patient, which would be totally different or impossible to do in the case of motor neurons because they can not be derived from
muscoletti artificiali di contrasto.
primary cells. It's really important for muscle contraction to happen in order to carry out more advanced studies than those that we can carry out in just a little thin layer of cells. And as you can see in this video, we can actually measure the force, the strength with which these muscles can contract in the laboratory. A few years back, we also showed for the very first time that we can also summarize, if you like, very specific characteristics of a certain muscular dystrophy conditions like this one, using this platform, these artificial muscles. Okay, I'm not going to go into great detail, but I don't think you need to be an expert in muscles to see that in this case, these red dots, which are the nuclei of the fibers, are quite normal. In the case of this disease, instead, where you have a problem with the nuclei, we see that there's a great extreme elongation of the structures. So we can study phenotypes, particularly complicated characteristics, in a way that we couldn't do in the past. The important thing that we're focusing on in this study is to make a shift, from disease models to therapy models. And we want to develop this on the basis of gene editing and gene therapies. A colleague will address this later. An example of what we're doing is shown here. Of course, there are limitations, but there are also positive findings with the use of AAV vectors. This morning, we heard there was great success, for example, SMA, as well as many other more complex studies that maybe were less complex, like myotubular myopathy and the Duchenne muscular dystrophy in that case too. So the idea is to use this system of artificial muscles on a predictive basis in order to determine the toxicity and possibly the specificity, if not the efficacy, of these vectors, even in the same patient, possibly, without the need to use an animal model, which might not reflect toxicity and or the toxicity of this virus, because the species are just different. This is why I have the pleasure of coordinating this network. It's a consortium, rather large. It's called MAGIC, of about 16 partners scattered through Europe, UK, US, and Switzerland. And we're trying to do precisely this. This project started in the middle of last year, mid-2023. The goal is to generate models like the one you saw, which are ever more complex and refined, so as to develop gene therapies and increasingly accurate and less or gene editing therapies with less toxicity. Here's the team, 8 academic labs, 4 biotech companies, and 4 patient associations, including Parent Project. And we had our kickoff meeting in June of last year. The team is composed of a number of groups with different skills and expertise, from virologists to clinicians, experts in immunology, because we want to avoid immunological side effects that we heard about just a while ago. This is a rather complex slide, just to give you an idea of the main goals of our consortium and the diseases that we study with these complex lab models: Duchenne muscular dystrophy, X-linked myotubular myopathy, and congenital muscular dystrophies related to LMNA and COL6 genes. We do both a screening of the AV vectors, but also of gene editing systems for these diseases. A trivial example that I wanted to show you, just to give you an idea of what we're doing within this trial and in the consortium, is this. We can take the platform I showed you earlier, and we can test different doses or subtypes of AV vectors to determine their efficiency in transferring a gene within a given subtype of muscular dystrophy. With a higher dose of AAV9, the green fluorescence is brighter. The same can be done with different serotypes and different types of AAV to determine which cells turn on, if you like, whether it's myofibers, vascular cells, and so on and so forth. Of course, we also want to use the system to be able to transfer therapies in these 3D models. And a small example of the work that we're doing together with my friend and colleague Mario Amendola, who plays an important role in the consortium, is this. With Mario, we conducted a study which is available on a bioarchive. It's a preprint server. We used our 3D muscles to look at the gene editing systems. Utrophin expression is increased here, and as many of you know, utrophin is a cousin, so to speak, of dystrophin, which could offset effectively the lack or absence of dystrophin if it's increased properly. With the gene editing system developed by Mario, we can see the expression of utrophin in our three-dimensional muscles, and when they express this protein, they contract. This study was hard to do using a typical classical system until a little while ago, because the maturation of these muscles and fibers is suboptimal in a single layer system, in a bidimensional one, and it can't be tested against strength. So with this system, we can definitely start testing possible therapeutic strategies directly in a humanized system, while in parallel we run the same study in a mouse. And I have finished with this. I hope to have kept the time allotted to me. I'd like to leave you with this message, which I hope you will agree upon. As George Bach said, all models are wrong, but some are useful. And we think that in our case, we have found a rather useful model to continue to conduct studies that will allow us to move more speedily for DMD and other muscular dystrophies. Thank you. This is the team that did the whole work. I'm here to take the merit, but I didn't do anything. I just presented a lot of the work done by these people in my lab in the picture. Our main co-workers are here: Francisco Pete, Mario Mendola, Andrea Serio, and thank you once again for your kind attention.
So questions at the end. So thank you very much, Severio, for staying very well on time. So well done. You didn't even need your extra 5 minutes. So the next presenter is Adrian Westhouse. He works in Geneton in France, and his talk is about improving viral vectors. And you have already heard several trials about the side effects of the vectors. And why is that? Well, we need a lot of vectors to get enough into the muscle, but a lot will also go into the liver, and that causes problems. There's an immune system and an immune response that causes problems. And also, these problems, they may be tolerable by younger patients, but in older patients, they might be problematic. So it needs to be better, and approaches to how to get it better will now be presented by Adrian. So the floor is yours.
Thank you for the kind introduction, and thanks for the organizers for inviting me to share some of what we are working with in the lab of Dr. Giuseppe Ronziti at Geneton. Just a quick introduction. Geneton is located just south of Paris, and it was funded by the AFM Teleton, so it's really focused on developing therapies for muscular diseases and studying those diseases as well. Geneton already has developed therapeutic approaches that has been brought into clinical trials. For example, includes DMD, but also myotubular myopathy, Crigler-Najjar, which is a metabolic disease that doesn't really have a muscle phenotype, and Pompe disease, another metabolic disease. Specifically in my lab, there's really 3 specialities that we're focusing on. One of them are metabolic diseases that affect both liver and muscle. The other one is investigating how gene therapies interact with the immune system, which is a really massively growing field because we're starting to understand what the problems are and actually how many problems there are. And the third specialization that we have in the lab, and what I'm working on, is the creation of new and improved technological tools, including, as Amico introduced, viral vectors for gene delivery. I actually only recently joined the lab, and my background is in viral vector engineering. I've previously been at UCL, so just like Severio, and the Children's Medical Research Institute in Sydney. I also want to have a disclaimer. This is actually the first time I'm presenting in like a non-scientific setting, so I really hope I broke it down enough. And also, as Amico already said, there are really no bad questions. Just ask if anything is unclear. Because I don't really know what the most important things are for this type of audience, I did highlight the messages that are really, I think, essential to take home with you. Just starting really basic, what we're working with is gene therapy. And gene therapy describes the process of treating a patient's genetic disorder by supplying a healthy copy of the affected gene. This sounds really simple, but there are really, there are obviously difficulties in achieving that. One is to understand what gene is actually affected. For DMD and BMD, obviously we know it's the dystrophin gene. And then the other massive challenge is how to get that gene where it's needed. For that, for most in vivo applications, so applications in the whole living organism, we're using adeno-associated virus, or AAV for short. The important take-home message here is, and everyone has been talking about viral vectors, or not everyone, but many people have been talking about viral vectors at this meeting. And there's one major reason for that, is that viruses have evolved over billions of years to deliver genetic material into cells. So nature has given us this tool that knows how to deliver. And now we are trying to investigate how best to use these features for medical applications. The main challenges for delivering dystrophins is the size. Not many viral vectors are able to package the entire cassette. Luckily, there have been people working on it, and there has been tremendous progress in making smaller versions of dystrophin called micro and mini dystrophin, and they are really helping patients already. So I'm not focusing on that because that's not my expertise. My expertise is working on overcoming challenges such as the delivery to the muscle fibers, which for now is still suboptimal. And to understand how we can achieve that, I have to introduce our delivery vehicle a bit better. The adeno-associated virus is not known to cause any disease, which is why we really like using it. And we know it's not known to cause a disease is actually that most of us here in the room, especially the adults, if you would take any biopsy from your body, chances are that there's AAV DNA in that biopsy is really high. So we know that every one of us is exposed to AAV, but no one actually gets sick from it. That tells us it's quite safe. It's also a really small virus, and that helps really engineering it. The small size, however, doesn't mean that there is not a lot of interesting information in it, because viruses are really good at packaging a lot of information in a small size. What we are really interested in are the structural proteins which form the viral capsid. So, I don't know if that actually works. Yeah. So what you can see here in the panel C is one capsid monomer. 60 of copies of this will assemble the entire capsid, which has this really complicated shape you can see here. And what's really important is that this viral capsid has really exposed surface loops, which you can see in the colored regions on the outside. And those are also called variable regions. This variable region indicates there's not just one AAV, there's actually many. And this is a concept that you are actually familiar with because of the COVID pandemic. If you remember, initially there was just coronavirus, and all of a sudden there was the Alpha variant, the Delta, the Omicron, and now there's still like 1,000 new ones. Luckily, they don't affect us as much anymore. But from that, you already know one virus is not one genetic sequence. There's always hundreds and thousands of them. And this diversity is mostly in these colored regions here. And this is what we can use to develop more targeted therapies. Very simply, to make a virus into a gene delivery vector is removing viral genes, which are responsible for capsid formation and the replication, with a cassette that expresses your gene of interest. And a great feature with AAVs is that this cassette can then be packaged into lots of different capsid proteins, which can affect where this DNA is being delivered. And we can do that with hundreds or thousands of naturally occurring variants. However, there's one major caveat, which is that these natural AAVs, when applied systemically, so infused intravenously, will always target the liver first, because the liver filters all the blood that comes back to the heart through the veins. And naturally occurring AAVs have been evolved to be extremely opportunistic because they need a helper virus to replicate, and because they're quite deficient by themselves, they have to be as opportunistic as possible when it comes to targeting certain cell types. If you inject it in the whole body, it will end up in the first organ that it targets. And this is why we can't fully rely on naturally evolved AAV variants. Luckily, though, we can use capsid engineering to create new AAV variants that haven't been out there yet, and we can specifically tailor them to target tissues that we are interested in as developers of gene therapies. Now this is where my talk starts to get a bit technical, but please bear with me, and it's only two technical concepts I need to explain to you. The first one is random peptide insertion, which you can see in panel A. Here we introduce, in a very targeted fashion, a random sequence that we call a peptide into the colored surface loops that I showed you on an earlier slide. And this is effectively helping us to fine-tune how the virus interacts with the cells that it sort of meets while traveling through the body. The second method is DNA family shuffling. Here we use existing viral capsid, fragment them, and then randomly reassemble them to create highly diverse and completely new sequences. So, as you can probably imagine, changing the entire capsid gene is a much more global change of what's going to happen with the final product, while the random peptide insertion is a more fine-tuning step. So they both have their pros and cons. Both of these techniques are used to really diversify the capsids that we have access to. And both of these techniques will give us millions, if not billions, of new variants every time we make a new of these experiments. And this mix of new variants we call a library. And to then find which one is the best out of a billion new variants, we need really strong selection mechanisms. And the selection mechanism we're using is called directed evolution. The concept has been awarded the Nobel Prize in Chemistry in 2018. And really the goal is to identify which variant is best for our really specific application. And for that, we create an initial library with, for example, the methods that I showed you on the previous slide. That library is then exposed on the tissue that we're most interested in. And by then recovering the variants that are successful and completely disregarding new variants that were produced but not actually interacting with our tissue of interest, we will end up with an enriched vector library, which can then be exposed again to the tissue we're interested in, and this ends up being iterative rounds, maybe 3, maybe 5 cycles, always depends on the library and the experimental setup. And at the end of such a campaign, we will have only a few variants that we can then test. And in most of the cases, really, the improvement compared to the variants that we start with is incredibly a lot higher. And yeah, so here, again, this is a complicated concept, but the take-home message really is directed evolution is effectively mimicking the survival of the fittest of Darwinian evolution, just that we don't have to look at birds on the Galapagos like Charles Darwin did over several hundred years, but we can use synthetic libraries and really fast forward the selection, and most importantly for a really specific goal by having a really good cell model where we're selecting on. And now I want to give you a few examples where this has been applied successfully to get new AAVs that target muscle cells. One of the first examples is a new candidate called AAV-MYO. This was identified in a large biodistribution screening in mice. And AAV-MYO is actually a peptide insertion variant of AAV9, so it has been produced with the method A from a previous slide that I showed you. And we know it's a better variant because it really has 2 characteristics that people are looking for in new variants for muscle targeting. And one of them is that it targets the liver less. So you can see here on the left AAV9, the parental serotype, and the new one AAV-MYO. In the first row, the tissue we're looking at is the liver, so we want to target the liver less. So less green means there was less AAV expressing in their tissue, and AAV-MYO achieved that. And obviously muscles like the diaphragm, skeletal muscles, and the cardiac muscle should be transduced more in a more muscle targeting capsid, and they could see that too. And this is quite remarkable considering how little is changed between AAV-MYO and AAV9. In fact, it's around 1% of the sequence is only different, but in a really targeted surface loop that makes then a gigantic difference for the overall specificity. As a sort of evolution of AAV-MYO, the same lab was then using the peptide that was selected in AAV9 that made AAV-MYO so much better than AAV9 into a new capsid that had previously been screened in mouse muscle, but from a shuffled library. So this was the second option here, this very global change of the capsid protein. So combining the peptide that's in AAV-MYO with this new shuffled variant resulted in what the lab called AAV-MYO2 and AAV-MYO3. And compared to AAV-MYO, it actually targeted the liver even less, while maintaining really strong transduction of skeletal smooth muscle and also the cardiac muscle. So this was a really interesting proof of concept that an existing, already improved variant can be further improved for certain aspects. You might have realized that all the studies I've shown you so far were developed in mice. As Saverio already told you, mice are not the perfect model. Mice are obviously not humans. And that's why there was another study published recently that was selecting new AAVs, not only in mice, but also in macaques, so small monkeys. Again, they're not humans, but they're much more closely related to us than mice are. And they performed a very similar selection to the initial AAV Myo with an AAV9 with a peptide insertion library. Interestingly, in both mouse and macaque, very similar sequences were selected, which to me personally is a bit of a surprise, but I guess it's very good for the field for disease modeling. And the peptide sequence is also extremely similar to AAV Myo. And similarly to AAV Myo, the liver was targeted much less. You can see that in the bottom row here on the left, AAV9, Myo AAV on the right. And muscles were targeted much more efficiently than AAV9. This also translated into the macaques, as I mentioned before. So again, we have a new variant here that's based on AAV9, and it's not only better in mice, but also in macaques. Now to wrap up, you can clearly see there are new variants coming up. However, the landscape of variants that are currently used in clinical trials is, I think, quite limited. And when you look at the new variants that were coming up, the starting point people use to engineer new variants, I think, is even more limited. So studies that currently are undergoing at Genethon, we are using new AAVs that have a much lower immunological profile, which is a topic I haven't really talked about today. But you might be aware that many patients are excluded from trials because they have pre-existing immunity. So we have capsids that react much less with sera, and we are currently engineering those. We're also applying new engineering techniques and to hopefully get even better improvement. And thank you so much for your attention. And again, thank you for the organizers for having me here.
Thank you very much. And again, questions will come at the end. And if you don't have questions, I have already a list. So the last presentation is from Francesco Gemello from Bologna. He will present on gene editing, and you already have heard the word Nobel Prize in the first two talks. Well, also the CRISPR-Cas system, of course, got the Nobel Prize for chemistry. Well, the approach, the ideal thing about gene editing is that you treat once and then it should be done for life. We already talked about exon skipping. Weekly injections, even monthly injections, is a burden. If we could treat only once, that would be better. But there's, of course, concerns also for the genome editing. What about safety? If you do it once, what if it goes wrong, etc. And what about muscle and delivery? So Francesco has 15 minutes to explain all of that. And of course, afterwards, we have questions if he doesn't manage to cover everything. So Francesco, the floor is yours.
Ok, can you hear me? Mi sentite? Scusate. Ok, grazie mille per
Thank you very much for your kind introduction, and I'd like to thank Parent Project for the invitation. Thank you all for being patient and sticking around until the very end to listen to the last presentation of the day. The title of my talk is Gene Editing Strategies for Duchenne Muscular Dystrophy. So I have the task of explaining gene editing, and to do that, I'll start with the beginning. And I apologize if my presentation will be too simplistic for some. Let's begin from the beginning by saying that our body, as many of you know, is made up by many building block cells. There are about 35 trillion cells in our body, and these cells play different functions. We have brain cells, skeletal muscle cells, we have liver cells, but all of these cells have the same instruction book, if you like, the genome. So in the nucleus, every cell contains a book of instructions on how to work. And this genome is a long string of DNA, or strand rather, which is constituted by 4 letters, A, T, C, G. And they are repeated billion times, and this is the instruction book followed by cells. Just to have an idea of what 3 billion letters means, it's all the 3 canti of the Divine Comedy multiplied by 5,000 times. You need 5,000 Divine Comedies, for those of you who have studied it. And in each cell, there are 5,000 editions of the Divine Comedy. So what can happen sometimes is that there is information that doesn't match, and those are mutations. There could be a change in a letter. There could be missing pieces. And Becker and Duchenne dystrophies are nothing really but mutations of the genome in the DMD gene, which encodes for dystrophin. And here I've reported the gene of dystrophin, which is made up by 79 exons, or pieces, if you like. And these 79 exons form a puzzle. You see the different shape of the different exons. In this pie chart, I am depicting the main mutations that cause the Becker or Duchenne muscular dystrophy. 50% are deletions of 1 or more exons. I'm sorry, 70%, which means that parts of this puzzle are missing. Then 10% could be mutations of a letter or duplications of pieces of the puzzle, or small insertions or deletions. In other words, a small number of letters is removed or written where it shouldn't be. Just to give you an example to make things more understandable. This is the region between exon 49 and exon 53. The pieces of the puzzle fit together perfectly. Muscle cells are able to produce dystrophin, which is the shock absorber of muscle cells. And what you see next to that is a section of skeletal muscle, transversal, a cross-cutting section. The dystrophin, which is colored in green, is expressed in all muscle fibers. Mutations, as here, where we have the deletion of exon 51, can cause pieces of the puzzle to no longer fit together. And in this case, we are out of frame, and the muscle cells are no longer able to produce dystrophin. Today, we've looked at several therapies that are in clinical trials or that are being developed in order to try to combat genetic muscular dystrophy. What I am responsible for is genome editing, or gene editing. I look at the DNA molecules where the mutation happens, which then causes muscular dystrophy. And this I do with a recently developed technology, CRISPR-Cas9. CRISPR-Cas9 is a system that we find in nature and in bacteria. And this is how it works. When a virus tries to attack the bacteria, it tries to introduce its own genome inside the bacteria, but the bacteria have a defense system. They have Cas9 protein, which is a molecular pair of scissors, if you like. And using a guide, it's able to recognize, like a GPS system, the viral DNA in order to use the scissors and cut that DNA. The system has to be super accurate because the bacteria have the scissors, if you like, that shouldn't attack the DNA, but that should be able to defend itself from the virus using the scissors in the right place in the viral genome. In 2020, the Nobel Prize was awarded to Emmanuel Charpentier and Jennifer Doudna, not because they discovered CRISPR-Cas9, but because they developed this system to edit genes and to apply it in gene editing. Now, very simply, how does this work? Well, we can use the RNA guide to bring the scissors to any region of the genome that we're interested in, and the scissors can cut the DNA. Once the DNA is cut, then you can have two repair systems that are already present in our cells. In one system, I introduce a piece of DNA that I'm interested in, and in another system, the cell removes or adds a small number of letters. Unfortunately, the system which introduces the piece doesn't really work very well in muscle cells. Instead, the second system that I described works quite well. This strategy, the single cut strategy, as a treatment for DMD, was developed in different labs, including Harry Cosson's lab, where I have the good fortune of working. What we used is that using the scissors, as we did in the Eric Olson lab, if we cut a specific piece of exon 50, we're talking about the DNA here, then we are going to skip exon 50. And therefore, it skips exon 50. Another possibility is that this cut can put in or remove letters, and this could give a new shape to exon 50. In this case, we're no longer talking about skipping, but reframing. I place the exon back in, I change its shape, and I put it in the frame. In both cases, a dystrophin comes back in the right sequence, and we have the production of a smaller dystrophin, which works, which is functional. What is a great advantage to gene editing? Well, it's a permanent modification of the genome. It modifies the genome, and the systems that I showed you introduce only minimal changes. With a guide, I place the scissors wherever I want, and that way I bring about a minimal change and introduce dystrophin once again. But there are a couple of disadvantages. One is that there's a cut in the genome, which means that signs of cell damage might rally other components. And the second problem is that insertions or the deletions of these small letters are random. So I can't really control how I'm changing the genome, and that could be very dangerous. To overcome these issues, but stick to the good part, which is introducing a permanent change of the genome, lately we have tried to use basic editors. Base editors were developed in David Liu's laboratory. They're a CRISPR-Cas-based technology. Base editors are not a scissor, but they're more like a pencil or a change which can substitute a letter with another one. For example, I can change a mutated A with a mutated G without unexpected results. I know exactly what I'm going to be changing in the genome. You will understand that this technology is very useful for punctiform or dot-like mutations, because I can change letters, a mutated letter with another one. But what we've done in the past couple of years was to develop and test this technology for exon skipping. going back to the example of the deletion of exon 51, cells don't produce dystrophin, but we can use the base editor to change one of the letters that we find in the splicing site, i.e. the site that defines what an exon is. In this case, destruction using a pen or a pencil in the splicing site means that there is recognition of exon 50, and so dystrophin, well, the pieces of the puzzle are back in the frame, and dystrophin can be once again produced by cells. To test this, we packaged the base editors and RNA guides in viral vectors similar to those that were presented previously, and we injected this system in a dystrophic mouse with a deletion of exon 51, which did not therefore express dystrophin. Here you see a section of the posterior muscle of the paw of the leg of the mouse. There is no dystrophin because there's no green, but after a single treatment with the base editor, you see that we have destroyed the splicing site of exon 50, and all the fibers of the mouse now express dystrophin. This strategy doesn't work only for this type of deletion. We also wanted to test it with other types of deletion. And as Saverio Tedesco said earlier, we took cells from patients and reconverted them into iPSCs, and for patients with the deletion of several exons like 40 and 52 and others, and then we transformed them into heart cells, cardiac cells. These cardiac cells do not express dystrophin because, well, the dystrophin should be in green, but using base editing with for these types of mutations, destroying other splicing sites, we are able to retrieve the dystrophin, which is shown here in green in the cardiac or heart cells. And this is my last slide. This is a vision for genome or gene editing. We start with patients. We try different strategies of gene editing, and then we moved into in vivo models, and hopefully we'll be able to do this in patients in the future. Of course, we also must consider the safety of gene editing for the future. It's a very powerful tool because we act on the molecule. We work with DNA, which is at the root of the dystrophin deficiency, but we have to be very careful. And there are other studies that need to be conducted on the delivery system as well. And gene editing is something that we're also using for other monogenic muscle diseases. One very last slide is to thank Eric Olson's laboratory, where I had the opportunity to conduct these studies, and at the University of Bologna, where I opened my new lab, at the University of Padua, where I continue to work, and you for your kind attention and your support. Thank you.
Thank you very much for staying perfectly on time. So I'm now going to ask all three presenters to take their seats up the podium so we can go to the Q&A. And, well, Ilaria can assist me if we have Italian question. But we already had the first question in English that I have written down. So the first question in English is for Adrian. And the question, because at the very end of your talk you mentioned about AAVs that don't induce an immune response. So the question was, how, I'm not as tall as Francesco, how far away are we from AAVs that do not induce an immune response when we use them for gene therapy?
So if we are interested in AAVs that don't induce an immune response like at all, or any
agent that we inject in the body that doesn't induce any immune response, I think we would need to wait a very long time because that simply doesn't exist. Our immune system, luckily, is just too good for that. So even if we have an AAV that looks very different from the ones that exist right now, where some of us have an immune system that's trained against, so even if we have something that is very different from that, our immune system is able to learn really quickly. And so just to keep it in simple terms, the quick answer is that will never happen. The question is, can we get it to a point where it's clinically really manageable? And I think that's going to happen fairly soon.
Yeah, and then maybe a related question to that I had, and was probably also part of this question, because if you use AAV9 as the starting point, then most likely the people that have pre-existing immunity for AAV9 will also have immunity to the new AAVs. So the ones that you're developing now, there ideally people would not have pre-existing immunity. Is that correct?
Exactly. So that's one of the main rationales. To start with one that's at the moment a lot less efficient to target muscles, but has very little pre-existing immunity. So here we really focus on engineering that sort of vector with all the knowledge we gain by engineering other ones to target muscles more efficiently while maintaining a low immunological profile.
And then maybe a last question for you that I had. So can you maybe very briefly explain the difference between encountering an AAV naturally, where they don't cause disease, and the AAV that we use in clinical trials where patients have side effects?
The really easy answer is that's just the sheer quantity of AAVs that we need to inject right now. We would never encounter that many AAVs with a natural infection. If we have a dose of something like 10 to the 13 per kilogram, a child weighs 10 kilogram, that's 10 to the 14 particles we inject. That's more than there are cells in the body. These are numbers that just don't occur in a single droplet that someone coughs in your face, luckily.
So the dose makes the poison, as the toxicologists always say. Are there questions for other people, or do you want to go through my questions?
Two questions for Francesco Gemello. I'm going to read them one after the other. One is whether gene editing can work on duplications, and the other is $1 million question. How far are we from seeing this method CRISPR-9 in a man? I'm sure Amico would have asked that question. I'll start with the when, which is the most difficult question. I think it's difficult to give you an estimate of time. When will it be possible to do gene editing on muscular dystrophy? As I had the opportunity to say, gene editing is now used in clinical trials for other diseases. So this is a good sign. Some issues for gene editing are the same that we have for other approaches for it to be used in clinical trials like the delivery and so on. So these are issues that are also under study for other strategies, and so I think that gene editing can reap the benefits of solutions found for other approaches. But as to the when, I really don't know. It's difficult to estimate. As to duplications, the duplication of exon 2, it's already been shown in cell models and in mouse models that it can work. Of course, gene editing can work in duplications, but then every single strategy, gene editing strategy, needs to be considered. The strategy presented by Saverio Tedesco with utrophin could work for duplications as well, theoretically. If I may, there's another question for you. It's a bit specific concerning deletions. Even if deletions are very large and concern 30 exons, can this work? We always talk about exon skipping, so the larger the deletion, the less dystrophin works as a shock absorber. But then, of course, we need to investigate the structure of the protein that would result with the deletions.
So then I see a question. I will ask a question to Saverio first, and then there's a question in the audience. So I'll ask it in English, and you can answer in Italian.
I have to think about that.
So what can you study with your muscle cell system that you cannot study in a mouse? So what makes it different and better?
Allora, l'esempio...
I think I already showed the example in my presentation, but anyway, there are situations in which the animal model is not, well, either it doesn't exist simply, or if it does exist, it cannot summarize the mechanism of the disease in humans. In the example of congenital LCND, muscular dystrophy, in that case, in the mouse model, we need to completely delete both copies of the gene to see the disease, whereas in humans, it's the opposite. One of the two genes, one of the two alleles, works toxically and causes the disease. In that case, we already know that the mechanism is totally different, and therefore, a dissection of that mechanism within the animal model in the mouse might not lead to a solution. There are other examples in which we have the absence. We just don't have an animal model that can mimic the disease faithfully. We're not very far in Duchenne. Giant leaps have been taken with mouse models. MDX, the one mostly used today, has limitations, however, compared to the natural history of the disease in humans. So as far as I'm concerned, I don't think that there is a binary kind of situation, black and white or one or the other. I think more in terms of the synergy of both systems to try to bridge the gaps of each one.
As a mouse doctor, I of course appreciate that you don't say that we shouldn't use mice at all. And maybe another advantage of the human systems is that if you do exon skipping studies or gene editing studies, you can use the human-specific targets rather than developing something for the mouse and then just have something that is great for the MDX mouse community but applies to 0 patients. So we have a question in the room.
Hello. Hello, I have a question regarding duplications, and I would like to ask you if exon skipping is eligible also for multiple exons duplications.
You want me to take that one?
I think Francesco can give me an answer.
You can also reply. I think you are more expert than me in exon skipping and duplication.
I will do it for AONs, and then you can do it for gene editing, where more is possible. So for AON, so the antisense oligonucleotides or ASOs, skipping more than 1 exon is not possible in humans or even difficult in mice. We can do it in cultured cells. We just overdose and we combine. We say, well, say you need to skip 40, 41, 42, 43, we make a cocktail and we add it in the cells, and you see skipping of all 4. If you do it in living organisms, the problem is that you will need to skip multiple exons. So you need to get the ASO for each of these exons into the same muscle fiber, into the same nucleus of the muscle fiber. And if you see now the exon skipping levels that we've heard, well, the highest that we've heard is 5%. So if you need to skip 2 exons, then you will get an efficiency of 5% of 5%, which is really very little. If you need to skip 3, it's 5% of 5% of 5%, which is nothing. So for AONs, if we would have 100% efficiency, yes, this would work. But the efficiency is currently so low that if you need to skip more than 1, the efficiency is just too little. And then for gene editing, you can probably do better.
Yes, regarding gene editing, essentially, you cannot use the strategy that I show you with a pencil, okay? Because for the pencil you have to destroy the splicing receptor site that is common with the other duplicated. But I think there are some papers that show that you can use the scissor, and with the scissor you can select the specific intronic regions that are specific for the duplication, and theoretically you can remove using not 1 scissor but 2 scissors. This is only a proof of concept for sure, so it means that in vitro could work, in cells could work, and maybe also in vivo in a mouse model could work, but the more thing you introduce, more complicated is the system, more we need to pay attention that it has to be safe. This is my point. So if we use 2 scissors instead of 1, it means that we have to double our effort to see if it is safe or not. But let's say that theoretically it should be possible.
Yeah. So it is possible, but also because you need to remove a big piece, that makes the efficiency less. If you just need to skip 1 exon or delete 1 exon, you need to delete a little bit, and then it will be efficient. But the longer away, so the further away it is, the less efficient it is. Do we have other questions on the WhatsApp, Ilaria?
Yes, but
yes?
I want to see if we
in the room, wave your hand. I don't see. Okay. Oh.
Altra domanda sempre per Francesco.
Another question again for Francesco Gemello. I guess gene editing is popular. In the future, could this be applied to patients who've undergone exon skipping or gene therapy before? I don't know if anybody wants to correct me on this, but I don't see why not. I would say yes. We work with the molecule which is responsible for the mutation, so we work with the DNA. We modify that. And as we said earlier, the timing to develop a strategy and a gene editing treatment for Becker or Duchenne muscular dystrophy the timing is a little bit long, although it's still unpredictable. If I may, I'd like to add a comment. One thing you need to think about in that context is the vector of the vehicle, because to deliver gene editors, you will have to probably use the same platform of AV vectors. So you've got an immunogenicity issue that we talked about earlier.
And to make more vectors so we can mix. Other questions in the audience or online? Okay, so I have a few, so if you humor me. So the first one is for Saverio. So when you do this IPS generation, so you make a cell, a skin cell, you make them back into a pluripotent cell, will they lose some information, some genetic information if you do that?
In teoria no, nel senso.
In theory, no. In theory, no. This rejuvenation of cells happens without us affecting the genome. This being said, this is a process that involves a lot of cell duplications, a lot of division cycles, and so it can't be ruled out that in this phase we may create mutations, and this is a reason why it is absolutely crucial to screen and to test these cells frequently to avoid having a result which is affected by a mutation that happened during culture in the lab.
Okay, so last opportunity for a question. I mean, I have one, so don't be shy. Last opportunity, question online, no question in the audience. If not, then I'll ask the last one to Adrian. So when you're developing these new AAVs, do you also take into account how easy or not easy it is to produce them in a large scale?
The short answer is yes. The question is always to judge when in the process of making new ones this should be a priority. And that's always a really difficult decision to make, because if we say initially we want to ignore all of the variants that produce okay but are not the best, then we might really lose a vector that's extremely specific. But then if we wait all the way until the end, then we can't produce it to a meaningful scale. It's also very difficult. So yes, we do screen for that, and then have to make a judgment call how important we think it is.
Okay, thank you for that. Nice to see. So I think if there's no more questions, then thank you to the three speakers. Thank you to the audience for all your questions and your attention. And we can have an applause, and then Ilaria will have some final logistic comments.
Grazie di nuovo a tutti, splendide presentazioni.
Thank you once again, everyone, for your wonderful presentations. Thank you, Amico. And now we have to leave the room here because, as I anticipated this morning, dinner will be served in this very room. So they need to prepare to set it up. We're going to have a wonderful festive dinner. There's going to be a theme. The theme is cartoons, for those of you who are interested. So we'll be expecting you punctually at 8:30 p.m.